Good afternoon, everyone, and welcome to the Shout Echo. Please know that we are recording these sessions for later distribution, and please know that anything listed in the chat does not appear in the recording. My name is Shreya Prasanna, and I will be facilitating today's session. A few quick announcements before we begin. To help us with attendance, please enter your name, affiliation, email into the chat function. To access the chat feature, please click on the speech bubble icon on the navigation bar at the bottom of your window. To all the Be Well Texas providers, please make sure that you identify yourselves during the session, or if you're joining via phone, please email your phone number and name to bewelltx@ithaca.edu. Some housekeeping, please stay muted unless you're speaking. If you join by computer, your mute button is on the bottom left of your Zoom controls. If you're on the phone, just press *6. We also encourage you to unmute and speak, especially during the discussion portion of the session. We want to hear from as many of you as possible, so please keep your comments brief to allow time for others to speak up. Or if you prefer, you can use the chat feature to share comments and questions. Please note that no protected health information is allowed in either the chat or our discussions, and that means names, emails, addresses, or any information that can identify an individual. If you would like to view closed captioning for this session, please navigate to the bottom of your Zoom window and select the Show Captions option. You may need to click on More at the bottom right of your Zoom screen to find this menu. Towards the end of the session, the Shout Texas Echo team will send out a link to an evaluation survey. All participants filling out the survey will be entered into a raffle for a $30 Walmart gift card. Our didactic today is on buprenorphine administration strategies, micro, macro, and standard dosing, and will be presented by Dr. John Weems. Following that, we will discuss a case presented by Jared Davis. We will start with some introductions, followed by didactics, Be Well program announcements, case presentation, and open discussion. Thank you all again for joining today's session. In the spirit of all teach, all learn, we encourage you all to share your experiences, questions, and insights in today's conversation. And with that, we'll begin with some introductions. Dr. Weems.
Thanks so much, Ray. I'm John Weems. I'm an internal medicine doc and addiction medicine specialist here at UT Dell Med with the Shout crew, and then at CommUnityCare, which is the big FQHC here in Travis County.
Thank you so much for joining us today. Dr. Walker.
Hi, everybody. Thank you for having me. I'm Blair Walker. I'm with psychiatry and addiction medicine at Dell Medical School and Dell Medical Center.
Thank you so much for joining us. Dr. Ramesh.
Hey everyone, I'm Jan Ramesh. I'm a hospitalist here at Dell Medical School and involved with Shout Texas. Nice to see everyone.
Thank you so much for joining us. Alana.
Hi, good afternoon, everyone. My name is Alana Bolton. I am a program manager at Dell Medical School and the director of Shout Texas. Thank you all so much for being here with us today.
Thank you for joining us. Jared Davis.
Good morning, everybody. I'm Jared Davis, RSPS, MHPS. I'm with Strategic Recovery Solution in Houston, Texas.
Thank you so much for joining us today. Jasmine Vidal.
Hello, everyone. My name is Jasmine Vidal, and I'm a CSTAP program coordinator. Thank you for joining us today.
Thank you. And with that, we will move on to our didactics today. Dr. Weems, you can take it away whenever you're ready.
I got my screen shared. I think I'm unmuted. Can somebody give me a thumbs up if they can see a screen, and 2 thumbs up if they can hear me too? Great. All right. Thanks everybody for joining, especially Blair, who's apparently joining from outside somewhere underneath an air conditioner. That's great. I love it. We are going to talk about different options for starting buprenorphine. This is I think the third or fourth in a series of Shout didactic sessions that we've had about different options for starting buprenorphine in the hospitalized setting. The focus today is how to micro, macro, and standard bup starts, and particularly what would sort of traditionally be called patient selection. But thankfully, we're in this new era of patient choice and trying to build up our patients' autonomy and respect their dignity by giving them the choice. And so the learning objectives of this session are less to sort of have an algorithm about how to choose which buprenorphine start strategy as the provider members of the team in particular, and for the rest of the care team, how to support the patients to both understand and feel engaged with that plan, but just to know what the tools are so we can kind of guide our patients in a more shared decision-making model. And then finally, to be familiar with some resources that are available to help us all with this. Don't have any disclosure. There's the learning objectives. Today's going to be case-based. So we'll do two cases, the second one in a couple of parts. And I'll just pause here for a little bit to let people read the case. I think this session will go great if there's a hot chat and if people want to unmute and sort of weigh in and ask questions along the way. I'm realizing too that I'm often not able to see the screen, so I'll read the case quickly for those who are just listening and can't see a screen. So this is case one, an admission for an osteo workup. So a 32-year-old opioid use disorder, stimulant use disorder, presents with acute foot osteomyelitis. This gentleman uses fentanyl IV, approximates at 2 grams a day, and methamphetamine. He recently had an episode where he was overamped for 1 to 2 days, and he was on his feet, staying up all night. He had foot blisters, which was followed by foot pain. In the emergency room, he had an MRI that showed early osteomyelitis in his foot. And so he was in an emergency room observation bed, awaiting an admission for further evaluation and management. The patient's goal, talking to him at the bedside, was to stay in the hospital and get treated, not to lose his foot if possible. On evaluation, his CAL score was 7, and this is a real case amended to protect this individual's confidentiality, but I'm telling me if I can't get well, I'm going to have to leave. So are there any questions about this setup so far, or sort of clarification questions about the case? Now I'm to a place where I can't see the chat. So Shrey, if anybody, oh, there's the chat. Perfect. We don't have any, great. So we'll move on to the next slide. So, when I was a resident, which is not very long ago, this was the options. The old misguided medicine had us offering a choice to patients of, well, you can get on buprenorphine or methadone if you can afford that and make it to the clinic, or we can try to get you through this hospitalization and minimize your opioid analgesic exposure. And Blair and I are working on an unrelated case today where this was the team's primary impression. It's like, we need to make a choice right here at the very beginning of the admission, buprenorphine for their opioid use disorder, which are great things, or minimal exposure. And I think what our patients are hearing, and what I've learned particularly from peers who have been on both sides and can teach about what this experience is the option really is what people are hearing is you can do what we say or you can go home. And this was not a setup that sort of enforced our patient autonomy and choice. And thankfully, we are in a new era where there are lots of choices. And so here's kind of a chart of the different ways we can get people onto buprenorphine. And again, the clinical scenario is a patient presenting with mild fentanyl withdrawal. So we have standard starts, rapid high dose starts, low dose crossover, and that Suboxone orange up there across the top, and then in methadone pink purple. The other options of methadone are full agonist opioids appropriately dosed to treat pain. So this is the options. And does anybody want to unmute or put in the chat what they would recommend to a peer or as the provider would recommend to this patient for starting in this scenario?
I'm watching the chat, Dr. Weems, so if something comes up, I'll let you know.
Perfect. Give everybody a second to think through. If you're looking at this and thinking, what the heck are all these? There's a couple of, they're available on YouTube, some prior sessions where we went over different how-tos about how to actually do each and every one of these and descriptions of what these different start strategies are.
So Gloria says Matt. Low
Love it.
dose.
Great. Dig it. Low dose. Yes, low dose. And then see Dr. Ramesh suggests rapid high dose or low dose crossover for full agonist for osteomyelitis. Dig it. Then Jared, a standard start or low dose crossover. Gary Latson, great question. Is surgery or anesthesia planned soon? And then to address that, so typically in the case of an osteomyelitis such as this, as soon as there's a high probability that that's the diagnosis we're dealing with, the options are either to go to the OR for definitive management, which typically means losing part of the foot that's involved, versus a biopsy, which would reveal micro information. So basically tell us what bug we're dealing with. So the patient could be offered an antibiotic course, which is typically fairly long, measured in months, to treat this. And that was and just for the whole team on the call today, some folks might be in the acute clinical setting less often. That's generally what's going on. You got to get somebody in the hospital, and then based on what you find out, it can go a couple of different ways. So that's the long version, Gary. I would assume that there is anesthesia and surgery planned for this patient. Polly notes, I'd want to treat the acute pain with oxycodone, then eventually high-dose bup. This is great. Berna Bain, thank you for offering that rapid high-dose plus full agonist. Dig it, full agonist plus low dose. Ooh, the options. And then our frigid hub mate player said, could also do bridge to Suboxone with hydromorphone, etc. But to your point, what does the patient want to do? Any are fine, assuming he's medically okay for methadone. Great points. And then Gary got back with coordination of playing with the anesthesia team. I love that, absolutely. And I think as often, our SHOUT model is to empower primary teams, which are typically generalists, internal medicine, family medicine, to take on the standard of care for folks with opioid use disorder. And that coordination piece, Gary, could not be more important in these cases. At the front end, when there's potential perioperative planning, absolutely. On the back end, to understand if there's going to be a take back to the OR, for instance, or if the diagnostic information from an initial procedure would inform subsequent interventions, that coordination is key. And it's also an opportunity to show our colleagues and peers that just because somebody is presenting with consequences of a drug issue doesn't mean that they don't get high quality coordinated care. So doing the standard of care addresses stigma, particularly coordination. And then Dr. Ramesh asked, why is there an asterisk on low dose crossover? It's because low dose crossover is the only one that requires taking, it can't go on its own. And what that means is when you're doing a low dose crossover, you're cross tapering. So the patient needs to be on full agonist at the same time. I hope that answers the question. And somebody's comment earlier sort of addressed how they would do this. But one of the challenges with low dose crossovers is to make sure that there's an adequate full agonist opioid on board for these patients, because this often goes south when there's insufficient full agonists, and so a patient is in a net negative opioid balance, so they are in opioid debt. They're having some degree of withdrawal, and such that the low dose overlap isn't working. The patient's in distress because we're not getting where we need to be with full agonists. There's a little bit more about this again in some of the resources we'll review at the end in some of our prior sessions. Great question. How about methadone? Verna, how about methadone? I think that's a great option. And when I was a resident, it was like methadone or bup. You got to choose one right now because it's really hard to go from definitely methadone to bup. It's less hard to go from bup to methadone, but you got to choose now. And I think that option, again, what I've learned from peers, that's just basically telling somebody you can do what I say or you can go home. Methadone is a great option if the patient has can make an informed decision about that. And the challenge is often what methadone looks like after discharge. And so we were talking with Jared earlier about patients' challenges accessing care, particularly with transportation. If somebody can't make it to a clinic 6 days a week, methadone is a difficult long-term option. It's also reasonable to offer, hey, you want to be on methadone during this hospitalization? We got decades of evidence that this will treat your withdrawal, and then we can make a decision about switching to bup on the back end or continuing methadone on discharge. Okay, great responses, everybody. I'm going to run with a couple of suggestions that a couple people made in these following slides I think would be good options in this scenario. Oh, this is from our Shout resource library, which is available with that QR code and at the website. Just really reinforcing that this is about options. Shared decision-making and patient autonomy are critical. And then the second box there really points out that fentanyl withdrawal and the drug supply are highly variable. And so it might even look different in Baytown than it does here in Travis County in terms of our patients' understanding of withdrawal and how often we're seeing unexpected precipitated withdrawal. So again, just making some notes here about our clinical approach in these cases. And the golden point here is to have a plan B and to make sure the patient understands all the options up front so that if for whatever reason something ain't working out, can move on to the next one. I think this would be a good case for standard buprenorphine start. And the reason is you have a patient in mild withdrawal who's uncomfortable and they don't have severe pain at the outset. So we'll review this a bit, but it deserves to be said that standard bup starts are the most familiar, the most evidence-based approach we have. And in the vast majority of cases, even in this era of high potency synthetic opioids, that works. And here's the schematic of how it works. We stop the full agonist and presuming he's coming in and on board with cessation of his use while he's in ED obs. We wait it out to see and observe him with CAL scores as those green dots head down and the state of agonism reduces and he heads into a negative opioid balance and withdrawal. And then we initiate the partial agonist buprenorphine and bring him on up, get him feeling better than a standard bup start. The challenge is, and it's worthwhile being sort of upfront with patients about this at the outset, is we don't know how long that's going to take. Could be a very long time, and the yellow dots could be a shorter time, little snow globe dots. And we're just not sure. And I think it's very helpful to hear from our patients what they're experiencing on the street to know more about local drug trends and what the sort of lived wisdom of our patients is about how long this might take, both given the drug supply in a particular area and our patients' own knowledge of their own body, because they're the ultimate authority on that. Some notes about standard bup starts, best suited for patients with uncomplicated medical or mental health conditions. It's the best studied. It's familiar to our care teams, which is critical, especially working with our nursing and patient care colleagues. And the challenges can be the longer fentanyl washout period. So for this gentleman who's saying, I'm going to have to go if this doesn't work, I'd lean heavily on the adjunct of comfort meds and maybe follow Dr. Walker's advice to, and I think somebody else mentioned this too, to get some oxycodone on board up front and then wait out a washout period subsequently. The other good work here, and this is suggested by a couple of folks, is the rapid high dose start. And the take home points on this one are, the rapid high dose gets you rapidly out of withdrawal and up to therapeutic levels. And again, this is not the same as ultra rapid detox. We're not taking people in a neutral opioid balance and putting them into precipitated withdrawal. We are trying to support people through sufficient withdrawal so they're in moderate withdrawal and then initiating high doses. One of the benefits, particularly in this case for this young man who's got an acute medical issue that we hope to get him hospitalized for, but also acknowledging that people have other complex social needs they need to take care of, and this might not be the only hospitalization for this issue. Rapid high dose offers a safety net. This is often talked about in the ED literature, meaning you get a bunch of bup on board and it stays there for a couple of days, which can be protective against overdose and help people kind of sort things out. So this can be helpful if you're anticipating self-directed discharge or rapid discharge from care. And if there's difficult outpatient access to care, this is often utilized. Rapid high dose is familiar to care teams. You know, it's CALS driven, and it follows a very similar protocol. And there's emerging data of safety and efficacy, and the references are down there from teams in Alameda County and there's not a lot of precipitated withdrawal in cases of rapid high dose. The challenges are, you know, this is a protocol that's developed in the ED, and so it's intensive bedside provider involvement. Typically, it's not for very long, typically less than 2 hours, but these are cases where the provider team needs to be available to support the patient and nursing colleagues at the bedside. Again, the longer fentanyl washout periods are a challenge, and well, that's a typo. It's not a lower starting dose. It's a big old starting dose. It's one of the advantages. So let me check the chat. Any questions or thoughts about using rapid high dose in this case? Oh, damn, I'm seeing Tobias. Thank you for sharing that. Tobias Ortega, thanks for laying it out there, man. Sharing in the chat, and I hope it's okay to read it out loud. A similar scenario happened to me. I had osteo in my back. I chose Suboxone and it worked. I began my recovery journey at that time. Today's my clean date. Damn. Wow. Thanks for being with us. 2 years. Awesome. Thank you for sharing that. The stuff works. And we're very lucky to be in a community with others who show that with their expertise and experience. Verna Bain asks, is there a specific CALS to start? I don't know off the top of my head what they used in these. It's between 8 and 12, and there's different protocols, but it's typically between 8 and 12. I think one of the challenges with CALS scores in this new area of high potency synthetics is patients who are terrified of precipitated withdrawal, or they know what they'll report one particular way, in a way that kind of preserves their, you know, they don't want to go back into that, so they might report fewer symptoms. And then patients who know that patients who are less familiar might report other symptoms that would lead to a higher CALS score. So the validity across patients with the CALS score can be somewhat challenging. And so I think a default is you're the expert in your body. You tell me, is it time? Are you sick enough? Another bit of wisdom from the ED is kind of a return to the physical exam and to look for physical signs that are more indicative of opioid withdrawal, particularly the opening up of those pupils into dryassis and yawning goose flesh, in order to help guide that decision about when to start. Case 2, we're stopping at 12:30, so we got 7 minutes left. So this is a case of acute pain. So folks can read on their own, or I'll read for those just listening. A 44-year-old with OUDs admitted with polytrauma after a motor vehicle accident. They report taking 20 to 30 blues by mouth every day. And that's, you know, the opioid du jour, typically fentanyl, other high potency synthetics. Their goal is abstinence from opioids and alcohol, and they prefer bup over methadone. They are concerned about precipitated withdrawal, and they ask, am I allergic to Suboxone, which is the trade name for buprenorphine naloxone combo product. At that time, their CALS score is 1, scoring for anxiety, and their last use was 2 hours ago before the wreck. So real case, 44-year-old, very concerned about precipitated withdrawal. Where should we go? Any thoughts for the chat? People want to unmute? What we might recommend for this patient with acute severe pain, reasonable likelihood of anesthesia and orthopedics being involved, potentially other surgical services. Dr. Ramesh is going full agonist. And Medea, I hope I'm saying that correctly, asking me notes low dose crossover. I think that's the emerging consensus, guys. I think that this is, again, one where we used to say, boy, we better figure out methadone or bup right away. And now I think it's an emerging consensus around the country. It's important to get on top of the pain fast and utilizing this new tool of low dose crossover to get people onto bup if they wish on the back end. let's say we went with that strategy of full agonist anticipating a low dose crossover. 4 days later, they've been in the SICU and they're back and forth to the OR. They're on a hydromorphone PCA. And for those who don't know, that means a relatively high amount of IV full agonist opioid can be delivered. There's a couple different ways it can go, but the patient has some control over when they receive the timing of that medicine. They're meeting with a peer. Their goal remains abstinence from opioids and alcohol, and they still prefer bup over methadone, and they're still scared of precipitated withdrawal. And the statement that stood out to me is, I can't do it, can't even talk about it. When we head to the chat, I think we had some wisdom there. So Gary shares, if surgery is imminent, full agonist in coordination with anesthesia is simplest, then transition to bup after. Love it. Treat the acute pain with full agonist, start MAT later, med per patient preference, dig it. Lindsay adds, is there any type of resource available for people who are using drugs around primary care providers and who are more open to working with people who use drugs in a less stigmatizing way? Great question. Often coming across this issue, probably for patients like this who are going to have medical needs. Lindsay's often finding that people using drugs are very hesitant to seek regular care, discuss their use with their doctors. I think that's a great question, and maybe one we take offline. Be Well Texas is available as, and my colleagues can speak more to that across the state. My sense is that some of the other medical needs would require additional care team members being involved, and that can be tough to find. But thank you for bringing that up, Lindsay. I'm hoping we can talk more on it. So I think we had a consensus that we're here on the full agonist and that low dose crossover is a potential option. Let's throw a wrench in this case and say this 44-year-old is, let's say they're from Bay City. They're in a private hospital nearby, and the plan is to step down to med-surg bed tonight. The night when you're seeing them again, they're coming back to your service. The patient has no insurance, and there's an anticipated discharge tomorrow, the very next day. Does this change anybody's management? Does this change where we're at in terms of these options? You had a patient, you thought, we got him through the surgery, definitively managed. We had talked about getting onto bup after the rough part of the hospitalization. Thankfully, things went well. But this patient is terrified of withdrawal, acknowledges it, and now they have to leave tomorrow. Oh yeah, Gary knows pain management is going to be a challenge. In part for reasons Lindsay brought up is that, these are patients absent the OUD would likely be, often when there's polytrauma considered for full agonist opioids over a longer period of time. Now, taking on that scope is not common in primary care practices. We'll skip this one. This is another version of the case that highlights structural violence, structural determinants of health, change clinical courses, and the care we advise and provide our patients. For patients who can stay in the hospital while the case management team screens for SNFs or LTACs, there are more options, and this has to enter our assessment. So some notes about low-dose crossover. It's induction without withdrawals, often how it's presented. I think it's a good way to talk about it with patients. We maintain a positive or neutral opioid balance with full agonists, in this case, a hydromorphone drip. And it's a good consideration for patients with significant fear of precipitated withdrawal or severe acute pain. The challenge is one of them is time. So it takes longer. And if a discharge is imminent, that doesn't mean a microdose can't be initiated with close follow-up. The thing is, you need the team that can continue this in the outpatient setting. So this is something that we could pull off with Dr. Ramesh, Dr. Walker, and I as we're transitioning shared patients here in Travis County. With certain conditions, we would be able to do this. it's much more straightforward to complete the cross taper in the hospital though. And as Lindsay pointed out, would be challenging in other settings. It's a high touch intervention. It is complicated. And that's one of the challenges outpatient is that we have to make sure we have the bandwidth for patient education and support to get through this. And then in the inpatient setting in particular, the implementation work needed with pharmacy and nursing is a significant lift for low dose crossover. So I'm going to throw up these resources as we're heading towards time and to check out the final couple notes in the chat. Any chance the patient can be discharged to a residential treatment program? Yes, Polly. I think that'd be a great option. I think one of the issues we encounter with our patients accessing residential care is that, on the one hand, they're very motivated and they're ready to engage in more kinds of recovery supports. On the other hand, when there's complex medical needs, particularly around pain, necessitating full agonists, that requires a high degree of collaboration with the residential colleagues. And if there's medical on site that can make it easier, sometimes policies get in the way. If there's policies against people taking prescribed medicines, that can be a significant challenge. But that is a big opportunity to start to really intensify the SUD care if a patient wishes while they recover from the physical elements. That's the long answer. The short answer is they wouldn't be accepted almost anywhere because of medical with our fragment and treatment system as is. Lindsay asks, if someone doesn't want opioids, could you use low dose ketamine? Ooh, great question. It would be a higher dose of ketamine than is used typically outpatient, but that is an option for these patients. Different discussion, but a very good option for perioperative pain, particularly in these patients. Great. Oh, and Adrian has a great follow-up to Lindsay's point earlier. Final point from the chattering teeth of Dr. Walker, who's shaking in her office, freezing cold. I hate to say it, I'd offer the microdose option, but I try to talk him into a quick switch, turning off hydromorphone early in the morning, gain a touch of withdrawal symptoms, and then high dose Suboxone several hours later for typical initiation. Yeah, it works well, and I've never had trouble. Then add back the hydromorphone if and when needed. Yeah, and Blair's, we've had cases where that's gone fairly well, even for folks with significant concerns about precipitated withdrawal. Something Blair's taught me is sort of a counseling approach of coping forward with a patient, of saying, yes, there will be a difficult time, and that could, typically 6 to 12 hours where this is going to be tough. We're going to have pharmacologic supports for you. At Dell Medical Center and other places, we have the incredible honor of having peers there to be a part of the team to walk with people through that difficult time, cope forward, and then switch back to Bupe with high dose. That is all we got. Couple take home, summarize the next minute. It'd be great. Here's a summary. Let the patient be the guide. Standard, high dose, low dose. When there's acute pain and fear of precipitated withdrawal, it gets complicated. And remember, patients deserve full agonists if they have an indication, and they're going to need a higher dose. We'll get through this together, invite supports and reassure the patients. And don't forget the comfort meds. All right, and that's all. I'm going to stop sharing and hand it over to, or I'm not sure if we do announcements or hand it to Jared to start taking us through our case.
We will do announcements, but maybe we have a minute or so if somebody has any questions. I do see a question from Lindsay about microdosing psilocybin. I'm sorry if I'm not pronouncing that correctly.
Yeah, mushrooms. So it's a great, you brought up so many great topics of importance that we follow through it. The idea with buprenorphine low dose overlap or low dose crossover dosing is that we're trying to find a patient-centered way that's appropriate to that patient, acceptable to them to get onto buprenorphine, but it's a cross taper. You're getting the dose upwards, which is different to, I think, what folks are talking about when they're talking about microdosing psilocybin. So there's this movement, at the American Society of Addiction Medicine, there was an editorial published by a lot of the people who publish a lot in this area saying, we have to stop calling bupe microdosing because it is different to psilocybin and other psychedelics folks are microdosing. I say because that's what our patients want to, it makes sense. And to be real, addiction medicine, it's not like bunch of brilliant docs figured this out. Patients have been doing this for years. And thankfully, researchers like colleague Kim Sue, who's an early publisher, listen to people who use drugs and have sort of elevated this to a place where we're now bringing it into the standard of care. And so from my perspective and N of one, if microdosing makes sense to people, and so that's typically how I talk about it. But it's different because we're trying to, if a patient wishes, get to a dose of buprenorphine where they, the withdrawal is handled and their cravings can go away, and they, make just whatever decisions they want about their life and where they go from there. Hope that helps.
Thank you so much, Dr. Weems, and thank you all for participating in the discussion. Keep the questions coming. Dr. Weems will keep looking at the chat, and in the meanwhile, we will move on to the next part of our session. Karen, if you could please share the announcements from the BVEL program. Thank you. To claim your CME credit today, please text attend 100-952-65 to 844-502-1338 by midnight tonight. Next slide, please. Do you have a difficult case that you or your team have encountered? CSTAT offers you the opportunity to present any challenge your organization is encountering and receive feedback from our hub of experts in the broader learning community. There is no need to prepare a formal presentation. We will provide you a case form to assist with your case presentation. You can email us at shouttx@austin.utexas.edu, and we'll drop this in the chat. Next slide, please. The 2024 Texas Substance Use Symposium is officially open for registration. This free event will feature complimentary education curricula, interactive panel discussions, and professional networking with national and Texas-based substance use disorder experts. Texas is also open to sponsors and exhibitors. To learn more on how to become a sponsor or exhibitor or to register, please visit the website texas.org. Next slide, please. Join CSTAT and Texas Health and Human Services for an 8-part webinar series to explore the intersection between behavioral health, substance use disorder, and COVID-19. Our inaugural session, Preparing for the Triple Threat, Rising Rates of RSV, COVID, and Flu, will be on Friday, February 2nd. You can register by visiting our website at cstat.utisca.edu, and we will also drop the registration link in the chat. Next slide. Please join us for our next shout session. This will be on Thursday, February 15th. We do have an interesting session lined up. And with that, we will move on to our case presentation. Karen, if you could please share the case, and Jared, you can take it away whenever you're ready.
Good evening, everyone. I'm Jared Davis with Strategic Recovery Solutions. I have a peer that I'm engaged with that I received from a colleague that works in the inner city, whereas I work out in the rural area of East Harris County. I'm uncertain of my colleagues and the peer interaction on his recovery path, but I would call my peer Mr. James. I have engaged with Mr. James on several occasions. I've given him resources. I've asked him how he want to go in his pathway of recovery. I've assisted him with some of the barriers he has. Mr. James is a 55-year-old man. He's still in active addiction and drinking and cannabis use. I've given him resources on where he can go to 12-step groups, AA meetings. I've also discussed with him what he would like to do as far as his recovery. I've advocated with him, with his family, try to get them to understand that he's trying to get help. But Mr. James only really engaged, that's not his real name, excuse me if I didn't make that clear. But Mr. James only really engaged if I have incentive for him. If I'm bringing him something from the food pantry, or if I can help him with some supplies for his house. He has a family that, well, I know his sister support him, but he's also with me, and I work with him as a peer and recovery support. I asked Mr. James basically where would he like to go with his recovery because it's his. And I would like to get some information from you all and input on how to get Mr. James to be more active in rebuilding his recovery capital. How would I go about motivating him?
Thank you so much, Jared, for sharing this case. We will open up the floor for any questions or comments on the case. Go ahead, Lindsay.
So I guess my question would be is who is this person, if it seems like I've worked with a lot of people with motivation, struggling with motivation, and a lot of that had to do with us trying to impose our idea of recovery on them as opposed to really working out what works best for them. And, have you had discussions with this person about other forms of recovery or like something outside of the 12-step group, like harm reduction and things like that? Or
Yes, ma'am. We have had conversations on what he would like to get. I've asked him, well, Mr. James, you say you want to be in recovery, but what is recovery to you? How would you like to go about it? I let him know that I'm his recovery coach. It's his recovery. It's not mine. So I can't tell him how to recover. But I've asked him what would he like to do and what pathway would he like to take.
I also found that like I would make goals with people who like just very basic things, and then when they can't accomplish it, like I had somebody that I got out of bed was her goal, right? And she got out of bed. So I just celebrate. Like that is the best thing in the world, right? And then small wins like that eventually led to them wanting to be more like active in their own recovery.
Okay, thank you.
I see a question here from Megan. What was he using? In what capacity did you see him?
Well, I know he drinks. He usually do a 6-pack almost every 2 days. I know he still has cannabis use, and I think that's on a daily basis, maybe all day if nobody's around. You know, uh, I have talked to him about his drug use, and he told me he had used some MDMA. I don't know how frequent he used that, but he's still in active use. But I won't give up on him, so I just try to work with him as far as how he want to go about starting his recovery. I gave him some acknowledgement on the fact that he decided to have a recovery coach. So that told me that he's willing to try, but it's still that it's more looking for incentive to help him in his recovery.
Yeah, I guess I was wondering, like, did he request to talk to you, or was it just part of his? I'm guessing you're working. I saw on the thing there was like a psych admit, so I'm guessing you're just on staff at the psych place, and it was just like protocol to get you involved, or like how much did he initiate the recovery angle of it?
Well, it was a colleague that initiated because it was her peer, but she's in there in the city. So she introduced me to him out in this area, and he seemed like he had a desire to recover, but that's why I say I'm uncertain of what their engagement or interaction was because I let him know what a peer specialist do, and how I can assist him with the resources. I'll be his advocate, And at the same time, though, he's good with that, and he'll make a statement that he's trying to stop. But at the same time, I called him still in active use when I came to pay him a visit. So yeah, I don't judge him. I can't put him down because of what he do. You know, it's still his choice. I just really want to try to be more of an encouragement and an influence to where he might want to go further with his recovery, but it's his.
Yeah, I would just be careful too with the alcohol use, because if you try to talk him into going to abstinence, they could go into DTs that could get real ugly. So,
Right.
you know, alcohols and benzos can get a little scary if they want to go cold turkey. So sometimes they just need a higher level of care, or at least need a medical professional in there. So, I guess it depends what you have in your network. Like, do you have a place he can go to groups on his phone, or groups in person, or do you have a place you can do counseling with, like an LCDC, or see a medical professional?
Yes, ma'am. Well, I do a Zoom support group every Saturday. Then I also giving him resources where he can log in on big book groups, uh, and 12-step groups. And this I understand is I can give it to him. Now, whether he use it is something else, but like I say, I don't discourage him. I just try to encourage him the best I can, that when he's ready, he'll get everything he needs.
He may not know what medications are out there. So is he seeing an addiction specialist?
No, ma'am. And I've offered him some medical resources to where he can go, because he also has some psychological issues. So I gave him a resource to where he can go to the Harris County Health Psychiatric Center. And he's told me he would go. He had been there before for about 3 days. I don't know if for some reason he won't go back, but within going there, I know he'll be able to receive the therapy he needs, the psychological therapy, and he'll also be able to talk to an addiction specialist.
Because he may benefit from Vivitrol that may decrease his drinking, and so I think probably you try to motivate him with MI and eventually try to get him into treatment.
Yes, ma'am.
Go ahead, Jared.
Okay. I do have this question because from my lived experience and being a former addict and alcoholic, I understand that when someone tell you what you need to do, that the most time people push further away from what's best for them. And so I really don't try to um, make no demands of him, but I ask him what he would like to do, and I also give him suggestions. I don't want to give up on him because that's not me. And I really want to know, is there any other type of way besides what I've done to try to help him to see where he might want to go? Because I can't push him
So Jared, I have a question for you.
there. Yes, ma'am.
And apologies if I missed something. I know he's still drinking.
Yes, ma'am.
Question is he still struggling? Because a few other people have thought about this, that, you know, it sounds like you, and I might be misinterpreting, but you are operating from a paradigm that he's not doing what he needs to do because he's still drinking. But as other people have said, some people can still use the substance they've struggled with and still be in recovery and still be doing better. And, you know, we sometimes talk about harm reduction, and drinking less might be his kind of okay surviving
Mechanism.
existence.
Yes, ma'am.
I'm curious what your thoughts are about that and how
Well,
and where he is with that, because that might not be where he is.
Okay. Well, no, ma'am, because I was a functioning addict. So it's not that I think he's not trying to recover because he's drinking. It's that this is just my observation. He's functioning with the little bit of alcohol he uses. It's that he's not. This is just my observation, though. He's not putting in the engagement as far as going further in his recovery. He feel like he's comfortable where he's at, and I don't knock him for that. But I'm trying to see if he wants more out of this.
So my
have a
question to you is that something that you need from him, or is that something that he really needs? I don't know.
No,
It's a hard question, isn't it?
no, man, I don't need it from him, but that's what I like I say, his recovery is his. I can't force it on him. I don't need it, but I'm at a point where I'm trying to help him the best I can, and I can't say how the alcohol affects him, but I know he does engage with me, and we go through the assessments. It, I you know I really can't tell you if it's good or bad. I can't, but I know this is just as me being a support specialist, and it might be one of my frailties. I wish the best for my peers, but I can't make them have the best if they don't want the best.
Well,
So
is his current, so he's coming, first of all, he's coming to see you regularly, it sounds like.
yes,
Which
ma'am.
means you're helping him some way, because he keeps on coming back.
Yes, ma'am.
I think that's the first really important thing, right?
Right.
But I'm just curious that you feel like he needs to go further, and you're struggling with him not going to the place where you feel like he needs to go to do more work, to be in better recovery, something that's different that's not now. And
Yes,
my
ma'am.
challenge to you is that coming from your own lived experience and what you think he needs to do? Or is that something that he really feels like he needs to do, and he's sort of saying, I mean, I'm kind of functioning, but I know I'm
Yeah.
doing the work. So to challenge you, I'm curious to know, and maybe that would be something to explore with him.
Yes, ma'am.
Does he feel like he's in a good place, in a healthy place? I think
Okay.
no matter what, though, he keeps on coming back to you. So you may feel more frustrated, but he may be doing kind of okay. And what you're doing is the thing that he needs that's helping him function. So I don't know, but it might be something to explore with him.
Yes, ma'am.
You're thinking with the peer supporters about when you're in a place, because I'm a psychiatrist and we have sometimes different ways of thinking about this stuff, and we have more of an agenda.
Yes, ma'am. And you're right, because of lived experience, and what I've been through, yes, I feel like it might be better if he go a little further, but I'm also good with the fact that we still have a great engagement, and I'm always there to be with him, and he calls on me. So I won't push it no further than he want to go.
It sounds like you care a lot about him and
Yes, ma'am.
want, the absolute best, what you see as sort of perfection for him, the best case scenario, and that you feel like maybe he's not there yet. But I would keep on exploring with him where he feels like he is, because maybe
Yes.
it's better than you think. I don't know.
Yes, ma'am. Thank you.
I'm glad
Yes.
to have you, though. And I think the most important thing is he keeps on coming back.
Yes, ma'am. All right. Yeah, because
I see Regina. Would you like to unmute and share your comment or question?
Hi, hello everyone. Well, she pretty much touched on everything. I was gonna say that because I keep hearing you saying about his recovery, but what is his definition of his recovery? What does that look like for him? Not, what I expect him to do would be, because I don't know. It sounds like he's fine. I mean, you bringing him supplies, you giving him everything he needs. He have his drink and his marijuana. I mean, like, ain't nothing wrong here, Mom. Not with that, you know. So his family is giving him a place to stay, you know. So, I mean, I would ask, you know, maybe, you know, just keep, you know, working with him and just show your presence, just show up for him, you know, being there and with no expectations, you know, until he decides that this is no longer working for him. You know, if that's what you choose to do, if he signed up for long-term coaching, I don't know, but you know, it sounds like he's okay with where he is, you know. I don't know, but I will explore what his definition of recovery is. What does that look like for him? You know, is he struggling with the fact that he's drinking? And, you know, is that a problem for him or is it a problem for you? You know?
Right.
So that's all I have to say. Thank you.
Thank you.
Thank you. Richard.
Hi, Jared, man. Thanks for your work.
Yes, sir.
I'm really peer specialist. Peer sport is meaningful to me. You know, earlier you mentioned, you know, how could you motivate him? And I think Lindsay brought up some good points. Everyone has brought up some really good points. And yeah, I think you said that you talked to him about what recovery, what did he want out of recovery, what recovery, what was like for him. But I don't know, like Regina was saying, it's just maybe taking that to a little bit further and having him define what recovery is to him and what he's looking for, and being able to focus on that. And then possibly when you work with him, you talk to him and he has behaviors that don't align with what he's calling good recovery or what he wants out of recovery, then you can use that to say, just kind of point out the discrepancies and just saying, I know this is how you define recovery, but then this is what you're telling me is happening, or these are some of the negative consequences, and then allowing him to make that decision on, well, then I need to change this or I need to do that. And then if there are some resources or some things that you could kind of bring alongside him to help him with that, then I think that would be ideal. I think really the motivation is going to come from him based on what he thinks or wants out of recovery. But I think really, just like a lot of people were saying, I think really having him define what he wants recovery to look like. He may say that where he's at is recovery for him, you know. So the main thing is his life where he wants it to be, and what can you do to help him get to another level if that's where he wants to go. So those are just some different thoughts that I had.
Yes, sir. Thank you.
Yeah, you bet.
Thank you, Richard. And that there's a whole bunch of comments coming up in the chat, but we are pretty close to time, so I will request Dr. Weems to please summarize the case for us.
Absolutely. Can folks hear me again?
Mm-hmm.
Yes.
No, okay.
Yes.
So 3 take-home points from today. Thank you, Jared, for bringing the case and everybody for bringing their wisdom to it. The first one is, where would we be without the wisdom of peers? You know, going from the start, alternative buprenorphine start strategies came from people with lived experience. Figuring out what person-centered recovery means, we're getting there with the wisdom of each other. The second one is shared decision-making is key. So when it comes to the bupe starts, let's explore menus of options with our patients. And when it comes to our work in the community, include harm reduction in that menu of options. And then another one that came out is setting small self-management wins to build interpersonal recovery capital. And finally, the third one, how do we motivate our peers and love people from potentiality into actuality? So we're following up on Holiday Monday and one of our national heroes, Dr. Martin Luther King. How do we, in a spirit of mutuality, bring out the best in one another? The theme in a lot of his sermons. And some of the wisdom that came out today was explore definitions of recovery with the person we're serving and develop discrepancy between that definition and the behaviors that might be going on. Thanks everybody for joining. Hope it warms up everywhere. I hope one day Blair Walker can take off her scarf and her toque while she's at work. Yeah, and we'll see everybody back next month.
Thank you so much, Dr. Weems, and thank you all for joining today's ECHO session. As a reminder to earn C credits, please text the activity code 1009-5265 to 844-502-1338 by midnight tonight. We also request you to complete the post-session survey using the link in the chat. The survey link will be open for 1 week. If you would like to present a case, please email cstat at please email us at shouttx@austin.utexas.edu. We look forward to seeing you at our next session on Thursday, February 15th. Thank you and have a wonderful rest of your day.